Hi, my name is Dr. Bodour Salhia from the Keck School of Medicine of the University of Southern California, and I'd like to welcome and thank all of you for attending my talk today at the 12th Annual Joining Forces Against Hereditary Cancer Conference. The diagnosis and prognosis of multiple diseases has relied on the identification of different biomarkers and blood tests. In the oncology space, this has some limited success, but with the emergence of new strategies, we are improving the way in which we can monitor biomarkers in cancer patients. So I'm going to talk a little about what biomarkers are and how we are entrenched with now measuring biomarkers in liquid biopsies, which is a new way of sampling the cancer. I have one disclosure to make. So a biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to some therapeutic intervention. More generally, a biomarker is anything that can be used as an indicator of a particular disease state or some other physiological state of an organism. So this indicator may be chemical, physical, or biological in nature, and the measurement may be functional, physiological, biochemical, cellular, or molecular. So the National Cancer Institute defines a biomarker as a biological molecule found in blood, other body fluids, or tissues that is a sign of normal or abnormal processes, or of a condition or disease. So biomarkers may be produced by both normal cells then and cancer cells, but are often upregulated or misregulated in cancer. So a biomarker may be a molecule that is secreted by a tumor, or could be a specific response of the body to the presence of cancer. So in cancer research and medicine, biomarkers are used in three primary ways. That is, first, to help diagnose conditions, as in the case of identifying early stage cancers. So these would be diagnostic biomarkers. So what type of cancer is it? Or to forecast how aggressive a condition is, as in the case of determining a patient's ability to fare in the absence of treatment. These are prognostic biomarkers. Or also to predict how well a patient will respond to a given treatment, and these are predictive biomarkers. We also have other biomarkers that are pharmacodynamic in nature, and they measure what potentially might be the optimal dose of a drug for a given person, or how a person, and then also to potentially determine if a cancer will recur or not. Ideally, biomarkers can be assayed in non-invasive ways, like in blood or serum, but not always. So again, biomarkers are of different types. They can be used for stratification or for monitoring, and then they can be used, like I said, for diagnostic, prognostic prediction, for determining drug dosing, but also for screening. We can also use biomarkers for screening. And there are different sources of biomarkers. We can, based on their characteristics, they can be classified as imaging biomarkers, which would use CT, PET, or MRI. We could use molecular biomarkers with three main subtypes. They can be volatile, so biomarkers from our breath or our body fluid, or also from tissue. Molecular biomarkers in particular refer to biomarkers that have biophysical properties that allow their measurement in biological samples like plasma, serum, CSF. And they include often not just protein measurements, but also include nucleic acid-based biomarkers, such as with using gene mutations and polymorphisms and gene expression analysis. But we can also look for epigenetic changes as well in DNA that we can get from blood or other body tissues that can be used for biomarker analysis. In addition, we can also test and look for lipids, lipid metabolites, and other small molecules can all be ways in which we can assess biomarkers. Many genomic and proteomic techniques are available for biomarker discovery, and also with emerging and evolving techniques, we can also use metabolomics and lipidomics and glycomics and secretomics to also look for biomarkers in these various types of, using these various types of techniques and analytes. A cancer biomarker specifically refers to a substance or process that is indicative of the presence of cancer in the body. The first cancer biomarker ever reported was the light chain of immunoglobulin in the urine, which was identified in 75% of patients with multiple myeloma in 1848. So quite a while ago. And there are a number of gene and protein-based biomarkers that have already been used at some point in patient care, and you can see a list of them here. Many you may recognize. So for breast cancer, the estrogen receptor, the HER2/neu receptor are very important biomarkers in the breast cancer space, but also BRCA1 and BRCA2 mutations, and they are also hereditary breast cancer genes, as you know, that have served as important biomarkers in breast cancer, and many others for various other types of cancer. BRAF for melanoma, CA125 in ovaries. This is one that we know is not that useful in ovarian cancer detection. So this is basically just a schematic of what and how this might happen. So if you have a tumor in the body, it essentially sheds information into the blood, which can be detected in the laboratory analysis. So the tumor will shed proteins that basically get into the circulation, but it can also shed nucleic acids that can also enter the circulation. Essentially, this shedding of the nucleic acid in circulation essentially forms the basis of what liquid biopsies are, and we'll talk about that in a minute. But this is what we want to do, is we want to survey the blood as a way of surveying the tumor. So historically, circulating tumor-derived protein-based tests have been the gold standard approach for screening guidance of different types of cancers. While widely used, though, they have had major limitations and have led to overdiagnosis. This is true especially for PSA and CA125. So current investigations are focused on the identification of protein signatures instead of a single protein to overcome the lack of specificity and improve the detection approaches. But in addition, there are also other things in blood that we can measure. Tumor-derived extracellular vesicles are lipid bilayer enclosed nanovesicles secreted by tumor cells that also carry protein and nucleic acids that can be used as biomarkers. And they can be found in almost every biofluid, especially blood. And they have been reported to be present at increased levels in different cancer types. But as I said, the tumor can also shed straight up nucleic acids into the blood. There are also circulating tumor cells that can enter into circulation that can also serve as a source of a biomarker. This is more of a cellular detection. And of course, metabolic markers as well. So there are different types of tumor components that can be detected in liquid biofluids of cancer patients. And again, these include circulating tumor cells, nucleic acid, which is specifically here referred to as circulating DNA or cell-free DNA because it's literally free of cells. It's naked DNA that floats around. Of course, like I said, proteins and metabolites, and also extracellular vesicles, white blood cells, and cell-free RNA. However, and common to all of them, the tumor analyte is often surrounded by a vast majority of non-cancer analytes, which are shed by normal cells, and this can hinder the isolation and detection of the tumoral fraction of interests. So the development of sensitive technologies has boosted an interest in this field and has allowed the use of liquid biopsies as a minimally invasive source of neoplastic material for molecular analysis. And each of these analytes, each of these cell-free DNA or RNA or CTCs has its own disadvantages and advantages and will provide different information. In some cases, just their mere isolation can already be informative, as is often the case with CTCs, or they can just be used as a starting material for biomarker detection. So liquid biopsies are basically a new non-invasive technique that can detect disease biomarkers in different body fluids, including blood, urine, and sputum. It is the sampling and analysis specifically of a non-solid biological tissue. And they are often useful when there is not enough tissue sample available in the body, there's not enough just tumor tissue available, and when a tumor is hard to reach, and also when regular monitoring is needed. You don't want to have a biopsy every few months to monitor your disease status. And liquid biopsies are analyzed for the presence of cancer cells, so looking for circulating tumor cells. DNA is a really big one, and also other substances that may be released by the tumor. So although cell-free DNA can be obtained from different body fluids, to date, the majority of studies have been performed with blood as the starting material. So this blood is usually collected from peripheral veins. However, it is unknown whether higher cell-free DNA yield and circulating tumor DNA proportion would change depending on where you would sample where the sampling site might be. And in spite of this exponential focus and advance in the field, we are still trying to improve and standardize the protocols that we are using, both for pre-analytical sample preparation and also after blood collection and for purification of cell-free DNA. So this is just a figure just to show you what we do with blood and what its components are. So if you were to take a blood sample, as many of you have I'm sure all of you have given a blood sample in the past, and that tube of blood is collected, when it's centrifugated down, you separate it into some three main components. You basically sediment all the red blood cells to the bottom. You end up with this interface here called a buffy coat, which is where all your blood cells are going to basically sit after you centrifuge down this blood sample. And then the supernatant component of it will either be the serum or the plasma that remains from the blood. So it's the liquid portion of blood basically becomes a supernatant and sits at the top. And this is mostly made up of water, as you can see, but it also has some pretty big proteins in there like albumin and fibrinogen and globulins and then electrolytes. But it also has your protein biomarkers that can be detected from this component of blood, and also cell-free DNA, which is present in trace amounts. So when we take a sample to the lab for liquid biopsies, we're interested in the supernatant fraction of blood, and we take that and we analyze it in whichever way we need to whether we are studying proteins or the nucleic acids or the microvesicles or the circulating tumor cells. So this is always the starting point. In addition to blood, there are different sources of liquid biopsies, as I mentioned. And again, this is any non-solid tissue in the body. So, you can do liquid biopsy assessment in CSF and saliva from pleural effusions, ascitic fluid, urine, and semen can all be sources for liquid biopsies, but blood remains the most common and the most widely studied and the easiest to access as well. And aside from urine, but there are some additional hurdles that we are trying to overcome when looking for DNA in urine and other things. So till now, solid biopsies, of course, as you know, have been the gold standard for clinical care, have been the gold standard for care in clinical cancer management with an unquestionable utility. They provide information about tumor histology. Standard biomarkers are used for subtyping and treatment planning, and also for molecular profiling and for predictive and also prognostic signatures with a very, fair and decent cost effectiveness ratio. But in the sense that the genetic landscape of tumors is spatially heterogeneous and temporally dynamic, the traditional method of tumor sampling by tissue biopsy actually has several limitations, including the fact that the tumor primary and or metastatic tissue is not always accessible and a biopsy not always possible. So on the other hand, the tumor molecular and genetic information is also limited to the biopsy area, possibly misleading the interpretation due to that tumor heterogeneity. On top of that, solid biopsies are incompatible with longitudinal monitoring and require an invasive procedure that may be painful and potentially risky to the patient. But again, because of the efforts of multiple groups and the development of different sensitive technologies, we have advanced the ability of non-invasive methods to detect tumor-derived material in biofluids and for them to be used in cancer diagnosis, prognosis, monitoring, and therapy guidance. So as a little bit of a recap from a couple of things I've already said, the term liquid biopsy is used then in contraposition to the traditional surgical tumor biopsy and represents the analysis of cancer biomarkers in tumor-derived material isolated typically from the bloodstream or the tumor circulome or other biofluids, like I mentioned. So I want to talk a little bit just about circulating tumor cells. So circulating tumor cells is a way in which a liquid biopsy test can be conducted, is to look specifically for the presence of circulating tumor cells. So these are a population of cells that have detached from the tumor mass and circulate in the bloodstream. And we have to travel 150 years ago for the first documented observation of the circulating tumor cell. And it was in 1869 when the Australian physician Thomas Ashworth observed cells that closely resembled the primary tumor in the blood of a man who died due to a metastatic cancer. And this is actually the original paper that I'm showing here. So, and he quoted, "The fact of cells identical with these of the cancer itself being seen in the blood may tend to throw some light upon the mode of origin of multiple tumors existing in the person." So, but it wasn't until, of course, the late 90s and the 20th century when the boom of CTC work started, after some groups developed the later and widely used immunomagnetic enrichment-based methodology for CTC detection. And importantly, they also demonstrated that CTCs exist early in disease and pointed out the potential use of these cells for monitoring treatment responses and recurrences. This method still hasn't been adopted as standard of care. There's still a lot of technical challenges that people are trying to overcome. It does require a lot of technology and instrumentation that also is hindering of sort of a wide adoption. And I just wanted to show you what I mean by that, just from understanding how cancer cells get on the move. So basically, the dissemination of a tumor cell into circulation is the first step in the metastatic process. And this process is often referred to as the metastatic cascade and involves the release of circulating tumor cells. So the mechanisms implicated in this process are still being worked out, but it is known that CTCs intravasate, so they get into circulation through a passive release from the primary tumor or through active intravasation associated with particular cellular transformations that occur. So once in circulation, cells then need to survive in circulation, but if they do survive, they can spread and they might end up establishing secondary and additional tumors in a distant site. So the metastasis is actually overall a highly ineffective event, and most of the cells in circulation die due to trauma and oxidative stress and attack by the immune system. But we know that patients do develop metastasis. So these cells, in many instances, can survive enough to basically travel in the circulation. So leaving the primary tumor, shedding, getting intravasating across the blood vessel, and then extravasating out of the blood vessel and forming a metastasis at a distant site. So I want to talk now about, so we talked a little bit about circulating tumor cells. Let me now talk about circulating DNA. So these are small fragments of DNA that circulate freely in peripheral blood of healthy and also definitely of healthy people, but of diseased individuals also. So in the case of cancer patients, a fraction of these circulating cell-free DNA molecules basically correspond to circulating tumor DNA. So again, if we look back, the presence of soluble DNA in blood was first reported in 1948. But it wasn't until 1977 when serum cell-free DNA levels were associated to cancer patients and the effect of therapy. So then we had to wait until 1994 for the discovery of the presence of a KRAS mutation in cell-free DNA extracted from a plasma of patients with pancreatic cancer. And in 2013, the FDA approved the very first liquid biopsy test called Cell Search. So that was for the use of CTCs. And then 3 years later, in 2016, the first cell-free DNA-based liquid biopsy test was approved for the detection of epidermal growth factor, EGFR mutations in the circulating tumor DNA of patients with non-small cell lung cancer who may then benefit from targeted therapy with erlotinib and osimertinib. But there are many limitations that remain unsolved, before routine clinical implementation of liquid biopsies in the field of oncology can happen. But, there are so many companies right now that have all kinds of tests that are either have had breakthrough designation by the FDA or who are CLIA certified, and especially in the space of early detection for cancer. This is becoming widespread. But essentially what I just wanted to show, as far as, we said the shedding of tumor cells directly into circulation, but in addition to whole cells getting into circulation, we also get molecules that are shed from these tumor cells into circulation. And the molecules that are shed actually also, they harbor the information of the tumor because they're coming from the tumor. So we can detect circulating tumor DNA, mutations, epigenetic changes, polymorphisms in blood without needing the actual physical tumor tissue, again, because of the shedding into circulation. And the circulating cell-free DNA has a very unique characteristic. It has a very certain length. This is chopped up DNA, so it tends to be small. And the sequencing technologies and just all the improvements in technologies have allowed us to do a really good job of being able to detect and monitor changes that are occurring in these. So these are then become a source of biomarkers. And again, this is just a rehash showing that, you know, the cell-free DNA released by tumor cells basically preserves the characteristics of the cell of origin and may actually better reflect the entire tumor genetic and epigenetic and proteomic picture rather than a traditional biopsy, because it can recapitulate the heterogeneity. So in the interest of time, I'm actually going to talk a little bit about so this is just a list of some of the emerging liquid biopsy tests that are coming down the pipeline. Some of these are already being used, and this is an exciting field for cancer research and cancer management, because you know, the sensitivities and the effectiveness that a lot of these tests are proving. Liquid biopsy can be used also across the spectrum of cancer care, all the way from screening to prognostication and prediction of recurrence. And, you know, and my lab, we're actually studying using liquid biopsies to look for screening assays for ovarian cancer and early detection and diagnostic tests for ovarian cancer, and also for monitoring minimal residual disease in breast cancer and for trying to predict recurrence. In the last couple of minutes, I just want to show you a little bit of data from my lab on how we're using cell-free DNA methylation liquid biopsies to try to improve diagnosis of ovarian cancer. And very quickly, basically, there are 220,000 women each year who develop a pelvic mass in the United States, and we can't preoperatively diagnose that pelvic mass as either benign or malignant. 80% of masses, pelvic masses, are benign. And this poses a problem because not only do we not know what the mass is, but we don't know how to treat the mass, and it isn't treated in the most optimal way, because we don't know if it's a malignant mass or a benign mass. So what we are doing is we have been developing a preoperative liquid biopsy diagnostic test for ovarian cancer. And what this test is intended to do is be very specific for detecting stage 1 cancer, because that's where the biggest problem is. The doctors don't have a hard time diagnosing in a woman with a pelvic mass a stage 3 or 4 cancer. But if she has a stage 1 cancer, it's very hard to discriminate that stage 1 cancer from a benign condition, such as just a cytoadenoma, a cyst, endometriosis, or other benign conditions of the ovary. So we have a test that we are working on developing that we believe can do this and can help lead patients to the right doctor, and also whether she's going to get referred to a gynecological oncologist or somebody or just a regular gynecologist to remove that mass. It's very, very critical for her management and her outcome. And we saw this slide. I'm going to skip the fact, just tell you that DNA methylation as a way to study this is becoming increasingly popular. It has lots of advantages. It's a very stable mark on DNA. So it just provides a robust way to look for disease presence by looking for these changes. And our test is basically performing very well so far in our early studies. And so I should end by saying that a central phase in the evaluation of biomarker is the assessment of its clinical validity. And in most cases, clinical validity can be expressed in terms of the marker's diagnostic accuracy. Also, we use sensitivity and specificity, which are also measures of a test's ability to correctly classify a person as having a disease or not having a disease. And we have a test that we are working on that we believe has excellent accuracy, sensitivity, and specificity. And I hope that with additional work, we will be able to use this for patients with who have an ovarian mass, but also as a potential screening test in the future. So I hope with that you have got a decent understanding of what biomarkers are and how we are emerging the utility of biomarkers with the use of liquid biopsies. And with that, I'd like to thank and thank you all for attending the presentation.